Can anyone hear us? Yep. Okay.
Hey, Steph.
Hello.
Hello.
Restarting.
Fantastic.
Hey.
Good morning. Good morning, everybody on the.
And Kelly, we're delayed on the minutes for this meeting, so I'll say so when we get to that on the agenda, but.
Okay.
What? We're just over. Yeah, I'm
Yeah,
sure
not
it'll be a
within
few
this
minutes,
room.
40, yeah.
A lot going.
You just sent the PowerPoint.
I am gonna go grab my phone.
Do we have a moment?
Do we have a moment before we actually?
Yeah, Olivia just had to get her phone. Yeah. And I'm just trying to get who's here. If you have a quorum.
How you doing, Rob?
I'm all right. How about yourself?
Okay, as long as the line. Let us know or we're with a forum with your.
Yep.
Can we do, when we start introductions, we can
Say that again.
do introductions of who's in the room, because we have
Hi.
new people.
Sure, yeah.
How's the baby?
She is great. Yeah, she's in 5 days a week of daycare now, so we're getting through that transition. As good as it can
My
go.
granddaughter's gonna go next Monday. For her first.
For her first day. So alive.
11.
Yeah, 11 is definitely important. Is Lisa Britt was here, right? I didn't-
She did go to the bathroom. She is exactly 3 months. My daughter goes back at 15 weeks, but,
Yeah.
you know, the daycare wants them at a certain time and
Sure. Yeah.
get to.
That's
So,
good.
I think
Yeah.
that was a good idea.
No, I
Get
think so.
everybody not working. Yeah. Oh, hi David.
Hey,
How's it going?
good, how are you?
Okay.
All right, so can folks online hear us okay? All right.
Yes, great.
Okay. There's like 3 different cameras into this room now sometimes. I don't know what causes that, but we'll keep it interesting. And we have a quorum, so Lisa, Brett, and Kelly, whenever you want to get started, I think we're set.
Great. Good morning, everybody. I know we have a new friend at the table this morning. So welcome, Lily. I understand you're the new executive director of Coalition for Aging, correct? Commission on Aging.
That's okay.
Welcome.
Thank you.
All right.
You want to do introductions around the room quickly for Lily?
Sure.
Okay.
Sure. You want to start, Teresa?
Sure. I'm Teresa Gustafson with the Office of Public Guardian. I'm Lisa Britt's alternate.
I'm Lisa Stevens, also with the Office of Public Guardian, and I'm currently the chair of the committee.
Thanks.
And I'm Kelly Cappuccino. We met in the elevator.
I'm Olivia May, I'm the Director of Medicaid Enterprise Development.
I'm Rob Berry. I'm the general counsel to Medicaid.
I'm David Charney, the Deputy Medicaid Director.
I'm Kristen Finnefrock, the administrative assistant for Medicaid.
All right. Well, let's get started. So first we have a number of rules on the consent agenda. My only question for the committee is if anybody wants to remove an item from the consent agenda or a discussion item later. Hearing none. I forget, do we move to accept the consent agenda?
A motion and then
Okay.
a vote.
All right, so we're gonna need a motion to accept the items on the consent agenda, those 5 rules.
So moved.
Thanks, Brooke.
Second.
Thank you, Kelly. Any discussion? All in favor?
Aye.
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 Any opposed? Okay, I only heard 4 ayes. Do you see more, Christine?
We type them in, even just type them in the chat if you're a member.
Christine said yes.
Don
Lisa
McKinney said yes.
Yes. Brenda said yes. We had 3 more votes.
Okay, excellent. Thank you so much.
Thank you.
All right. We understand from Olivia that the April minutes are delayed, so we're not going to be able to do a review and approve of those today. I think you said you were hoping to be out today?
Yeah, I'm hoping to get them distributed today, so we'll be
Okay.
in good shape to review them.
Okay. All right, very good. Thank you. All right, I'm just flying through here. So membership subcommittee, this is sort of a glitch, right, Kelly?
Well, we had people, I think, swap roles. And so the membership committee, really, it was Brooke and I, reviewed the application. We, recommended, the nomination, and do we need a vote here?
I think so.
Yeah. So,
Right.
the vote is for Ann Bognac to be the new alternate for CSNI. Can I have a motion, please?
So moved.
And seconded by Brooke. Any discussion? Perfect. Thank you very much. Welcome in into your continued role.
Okay, let's jump into the BAC, so Beneficiary Advisory Committee, Subcommittee work. Kelly and Olivia, you're up.
Do you want me to just kick it off? So we are continuing to meet with the BAC subcommittee, which has been a very helpful group for planning ahead for this subcommittee. We've gotten a great number of applications, which is very exciting. They do sort of skew mostly towards caregivers at the time being, parents and other caregivers of individuals who have been on Medicaid or are currently on Medicaid. So we are looking to get more applications from individuals who are themselves on or recently on a Medicaid program. So we're reaching out within the department to some partners there, but as sort of an ask to anyone on the MAC meeting today or in general, if you have outreach ideas and connect on those, we appreciate the support and go ahead and reach out to me on that. We also have, I think, a full draft now of BAC bylaws, drawing on other states that have had a BAC in place longer. And we'll be continuing to meet with the subcommittee, and we're still targeting to have our first meeting at least scheduled by July. So forming that initial group of BAC members by July. One other thing I'll just quickly note is once we start, seating folks on the BAC, we'll need to look at the overlap of BAC and MAC members, because there's a federal rule about, having a certain proportion. I know Kathy has already agreed to serve on the BAC as one of those overlapping members, which is great. And we're going to be reaching out to one other individual who has a beneficiary seat on the MAC currently for that. So just another kind of administrative item on the radar as we put that group together. Are there any questions or comments on BAC?
Anything in the chat, Kristen?
Yeah, I apologize.
Oh,
My
sorry.
Wi-Fi isn't working, so I can't see the chat.
Hold on.
Which I'm usually keeping an eye on.
They were just voting
Okay.
from previous,
Okay.
but nothing else.
Very good. Thank you. All right, well, thank you very much for that.
Thank you all.
It's been fun.
Has it?
Yes, it has been.
All right. So we have items identified for future meetings, including the MEA.
The MEA I know will be a presentation item in the future. And then the other two we're just keeping on here for any additional questions from members that might inform the future agenda item. And then, of course, any other things that folks want to raise.
So for both members and just folks from the public, are there other items you would like to suggest for a future agenda? Okay. Obviously, if something comes to you, you can offer it up at any time, but we just save space on the regular agenda if someone has something that they want to offer. Okay. We are just flying through today. Dave and Olivia, sorry. You want to talk about the MAC transition and those bylaws?
Yeah, so the MAC, we've released a survey, and I think we've heard back from almost everyone, which has been very helpful to inform updating the terms for all the members. Because just to recap for folks, our goal is to not have everyone on the same turnover for the terms that we have to establish under the new federal guidelines. So thank you to everyone who responded to that survey. And as a next step, we're going to go ahead and start kind of giving folks terms that are at least as long as people have asked to stay on, but then have a date that staggers so that not everyone's lined up on the same month. So that's one item of business that I think we're in good shape on. And then Kristen, I think we have a meeting scheduled for the bylaws subcommittee.
Yeah, not this week, I think next week.
It's next week. So thank you for everyone who's volunteered to be part of that subcommittee. I know we're a little bit behind for getting those bylaws reviewed and updated, but I think we'll be able to get them presented on the next MAC meeting.
Yeah, and, you know, thanks to the people who have been on the BAC bylaws, that really was sort of what was
Yeah, the big
taking
update.
taking precedence, and took a bunch of time. We had to ask people to reconvene a number of times. They were very generous and flexible with their time to get us to where we needed to be.
Absolutely. Are there any other questions or comments on the MAC membership transitions?
Great, thank you. Rob, do you want to give us some legislative updates?
Yeah, you guys are really. Yeah, sure. So the most exciting thing is I finally figured out my issue with the links in the bills. So this thing called Google, it's a wonderful thing. You can type in questions and it'll give you answers to things. So I did that and I was able to figure out the links. So now the Excel spreadsheet that I just passed to Kristen about 15 minutes before meeting began should have all the links in it and it should be up to date. So I'm going to highlight a few of them. There are yellow highlights in the spreadsheet that I put together. That's mainly so I can remember to touch upon these bills here, but these are the ones I'm paying attention to this week. I just want to highlight the committee's attention. And we're in mid-May now, so we're starting to get some bills that are actually getting passed and signed into law or are awaiting signature. So we're starting to move towards the end game here for the legislative session. Anything else? We'll start with HB 392, which is directing the dissolution of the Department of Health and Human Services Office of Health Equity in the Department of Environmental Services sub-functions for civil rights and environmental justice. And that was retained in committee, so it's not going anywhere at the moment. Moving on to HB 72, no 3 to 72, extending the commission to study telehealth services. That was signed by the governor, so that is now law. Moving on to HB 73, relative to harm reduction, substance misuse, and the governor's commission on alcohol and drug abuse prevention and treatment. That is a waiting signature.
What number is that?
HB 73.
Thank you.
And I guess the governor could, in theory, veto it, but I put a waiting signature just as kind of a placeholder for when it's ready for that. HB 94, relative to coverage of circumcision of the Medicaid state plan, that was ITL by the Senate HHS committee. There's a similar provision in HB 2 as well. But given the Senate's reception of the bill, I can't imagine it will stay in HB 2, but you never know. Moving down to SB 18, permitting the Commissioner of Health and Human Services to authorize additional beds for pediatric intermediate care facilities. That is also a waiting signature. SB 92 is relative to the collection of birth worksheet information. That is a waiting signature. SB 34, relative to parental consent for student participation in the Medicaid to Schools program. That has been retained in committee. HB 524, repealing the New Hampshire Vaccine Association, that's also been retained in committee. HB 265, this is just an interesting point for MAC, requiring that a public body's meeting minutes include start and end times of the meeting and the printed name and signature of the recording secretary. So that is, I think that is a waiting signature. It is a waiting signature, so that will be law in theory. Unless the governor decides to veto that for some reason. I can't imagine she will. SB 119, relative to Medicaid pharmaceutical services. This was a bill requested by the department. It was originally intended to allow the department to utilize brand name drugs as opposed to generics in certain situations to take advantage of rebates. The bill was amended. There was one provision in the bill where it would allow the chief medical officer to issue standing orders for over-the-counter drugs. That was removed by the committee. And the committee added a provision relative to standing orders for ivermectin. So that created some controversy on the committee. And along party lines, it was passed out 10-8. So it was not passed as amended. There are provisions that we asked for, specifically the pharmaceutical provisions and the provisions relating to the chief medical officer are in HB2. So we expect that it will remain in HB2, or at least we're hoping it will. So moving down to HB 357, relative to the Department of Health and Human Services rulemaking authority regarding immunization requirements. That was ITL. HB 679, relative to immunization requirements in general, was also ITL by the Senate. HB 634, repealing the New Hampshire Council on Autism Spectrum Disorders. That was ought to pass as amended, but the amendment restores the council. So the actual original bill repealed it. The amendment restores it, but they haven't changed the name of the of the bill yet. So that's what Senate ED&A did. That was just their recommendation. I think the Senate still has to vote on it as well, and then it'll have to go back to the House for concurrence or not. HB 732, to enhance consent and accountability in psychotropic drug prescriptions for children under Medicaid. That was ITL. Relative to reports by the Department of Health, this is HB 455, relative to reports by the Department of Health and Human Services regarding Medicaid enhancement for children and pregnant women. This just amended the timeframes for making these reports. That is awaiting signature. SB 250, relative to pharmacists' administration of long-acting injectable drugs. That is also awaiting signature. SB 134, relative to work requirements in the state Medicaid program. That was retained in committee. So I don't know if that's the end of it for this session. They made it very clear, the committee did, that they want to make it a meaningful retention. So as opposed to just a polite way of killing the bill. So I expect there'll be some work to be done on that end. They're still at the HB2 process. It hasn't made it into HB2, but we're still a long way from knowing what that's going to look like. But the committee did seem like they wanted to wait to see how the federal landscape played out prior to making any sort of decisions on that.
Can I ask a question?
Sure.
Can you just give me an example of two of the highlights of that bill?
Of SB 134?
Yes.
It would essentially require, I think there's really only one highlight. It would require us to resubmit the 1915 C waiver.
Okay.
Yeah, so it'd be the same exact program. 1115, sorry. 1915 is home and community based. Thank you. So it would just require us to do that again. Our argument was that there's a lot of unknowns out there in the world right now. It might behoove us to wait and to see how the federal landscape plays out before we move on.
And it was included in the reconciliation that got released, the markup, I think last night. It's included in that at the federal level. So.
Thank you.
There was no other highlight in there, was there? Other than that, okay. Just the one highlight. SB 257, establishing committees for the state guidelines for Medicaid eligibility determinations. That was recommended ITL out of the committee, mainly because they didn't want another commission that, I guess I'm paraphrasing, they didn't think produced anything meaningful. That was kind of again, I'm paraphrasing, but that's what the.
Someone in the chat's asking what's ITL.
Oh, ITL. That is inexpedient to legislate. That's the polite way of referring to as kill a bill. Supposed to kill bill. Moving on to the big one, HB2. I'm going to just try to hit some highlights there. It came out of the House with some what's the polite word for it? Some concerning provisions. I did read that the Senate has rejected the Medicaid rate reductions. They have restored the wait list and community mental health support funds as well. That's what the Senate has done. Some other highlights of what remains in the bill. This is not meant to be exhaustive because I could spend probably 2 hours just on this. But we have Medicaid prescription co-pays in there moving from up to $4, I believe. We have one rate filing per year for Medicaid managed care as opposed to the 2 we do now. It institutes premiums for Granite Advantage members as well as households with children that have a income greater than 255% of the federal poverty level. It directs the department to let the E14 authorities expire. The circumcision provisions are back in there. It also amends the Granite Advantage funding mechanism a little bit, or maybe not a little bit, quite a bit. And there's a provision in there for termination of Medicaid to schools should anything be done at the state or federal level that would infringe on parental rights. So that's some of the highlights in there. There's a lot more, like I said. Anything else you want to add?
Stevens has a question.
Sure.
Hey, Rob, I just had a question about the co-pays for Medicaid. When Henry was giving his giving the briefing to Senate Finance, he said, and these were his direct words, so I don't know what he meant by it, but that schizophrenic meds would not be affected by the increased co-payments. Didn't know if that means all antipsychotics or if that means medications for folks with schizophrenia. Do you have any idea what he might have meant by that?
No, actually, that's the first I've heard of it. So I don't know. David, do you know?
No, we can check. I know we've been talking about, there are different policy ideas around what could potentially be carved out from the pharmacy copays. And I think one thing to remember is, if a household was charged a premium, they wouldn't be subject to copays. But with specific to the psychotropic drugs, I can take it back and
Yeah,
agree on that.
a lot of folks who have chronic mental illness are on Medicaid that would be subject to the co-pays because it's one of the ones for folks with disabilities. So it wouldn't be subject to the premiums.
Okay.
If you could find that out, I would really appreciate it. Thank you.
I will.
And then I have a question, probably everybody knows this except for me, but can you speak a little bit to the GA funding mechanisms?
Oh, I have to go read that again. Hold on a second.
Doesn't have to be that detailed, but.
Do you remember off the top of your head?
No. Oh, sorry.
The Granite Advantage funding mechanism.
So currently, right, it's all liquor fund. It's outside of the budget. The HB2 provision would have general funds instead of liquor funds, and to the extent that there is a shortfall, fiscal and the executive council would need to approve additional dollars.
Thank you.
I think Lisa DiMartino also has a question.
Lisa?
Can you hear me?
Yes.
Okay, great. Question about the back of the budget cuts to the department. Where does the Senate budget stand on that?
I don't think I've heard anything.
Yeah, have you heard anything?
Go ahead. I don't think I've heard anything specifically on that. It doesn't mean there's not conversations going on about it. Like I said, there's a lot going on. It's moving very, very rapidly. Not everything makes it to me immediately. Sometimes I have to do some digging to find some stuff out. But I haven't heard anything specifically. I can look into that for you though, if you'd like.
I would, and I mean, we know this is going to have to go to committee of conference. And it'll be interesting to see how that's all gonna play out. But okay, thank you very much.
Yeah, and that's a good point, is I don't foresee this being like last budget where the House miraculously concurred with the Senate's amendments. I think this will be a long drawn out process as well, so.
Yeah, I agree. I think so too. I think I don't think this is gonna be pretty, but that's just my opinion, being a former state rep and knowing some of the people down there. But thank you.
Thank you.
Are there any words to the wise for those of us who are watching out for your members?
Words to the wise. I mean, I think what you would just do is you'd want to reach out to members of the Senate Finance Committee, your actual senator, even your representative in the district, and just let them know how this will affect your members and your constituents, and just be vocal.
Yeah, same. So
Yeah, and I mean, they did indicate the rejecting the rate reduction was as a result of advocacy. So it does help. And that's all I can recommend, is go out, advocate for what you want to see or not see in the budget. So, get as many people on board as you can.
I'm not sure if we have on this agenda, I'm just trying to look ahead, any conversation about the federal discussion going on right now. But, we have seen some of that too. So when I'm listening to New Hampshire, as you all have to do every day, I'm just trying to balance it, when do I act? When do we hold? And always with the best interest of our members in mind,
So, I mean, from the department perspective, we try to be as proactive as we possibly can, just to let people know what will and won't happen as a result of certain decisions that may or may not be made. What they're going to do is what they're going to do, but you can at least put out there what the effect will be.
Yeah.
And it's never too early. I'm not saying you have to go beat down their doors, but you can certainly, phone calls, emails, they do respond for the most part, at least the ones I deal with do, and that's the best you can do, I think.
thank
When
you.
we get to department updates, we can share a couple, just high-level updates on the federal level too.
Thank you.
Thank you.
Sorry, just because I can't see the chat, is there anything in the chat, question-wise?
Just James' question about what was
ideal.
Oh,
Hey, shh. That was loud.
Friends, if you would mute
Jody, you're
yourselves if
muted.
you're not
There
talking,
you
that
go.
would be swell. Thank you. All right. Someone's going on. So can we move on to dental organization technical support or report? Do we have
Oh, yeah,
HSAG?
yeah, HSAG's online.
Hi, this is Sarah from HSAG. Let me get my screen shared here. Okay, so good morning. My name is Sarah Landis, and I'm the Director at Health Services Advisory Group, or HSAG, who manages the EQRO contract with the New Hampshire Department of Health and Human Services. As you may know, the states operating a Medicaid program are required to have an external quality review organization to conduct several external review activities. And HSAG has been the New Hampshire EQRO since the beginning of the contract. So today we'll cover the two types of external quality review activities that HSAG conducts, including DO evaluations and dental Medicaid care management program evaluations. And we'll get into more detail regarding those activities in the upcoming slides. So please note, I did want to mention that the slides are a summary of the comprehensive information provided through the State Fiscal Year 2024 EQR Technical Report, which was submitted to DHHS in April of 2025. So first we'll review the DO evaluations. And we'll start with contract compliance, sometimes referred to as the compliance reviews. There are a total of 18 standards that are part of the contract compliance review. However, 2 of the standards, Standard 5 for behavioral health and Standard 14 for substance use disorder, are not applicable to the DO. The behavioral health standard includes items related specifically to what MCOs would manage, such as coverage for behavioral health medications and prior authorization for behavioral health services. And then the SUD standard includes items such as ensuring SUD services are covered through the full continuum of care for members with substance use disorder, which also is specific to services that the MCO would provide. And then although these 2 specific behavioral health and substance use disorder standards were not applicable to the DO, there were requirements that were related to behavioral health and SUD throughout other standards that did apply to the DO. For instance, in the member services standard, the DO was required to screen for special needs, including behavioral health needs, during their initial welcome call to the member. And within the care management, care coordination standard, the DO was required to identify members with substance use disorder as a priority population. Additionally, after the review, DHHS also determined that Standard 2, emergency and post-stabilization, was not applicable as all emergency services are covered under the MCO contracts, including dental. So during the first year of the contract, we review all of the 15 standards for the DO. And then every year after the first year, we'll review roughly 1/3 of the standards. So all of the standards are reviewed over a 3-year period. Then since 2023 was the first year for the DO, we reviewed all 16 standards, started with 16, and then we made the emergency and post-stabilization care standard NA. So we did review all 15 standards during the 2024 compliance review. Various items or elements were reviewed within each standard. And some standards include additional checklist items and some include file reviews. It is important to note that the compliance reviews focus primarily on the required policies, procedures, and processes, and do not necessarily reflect member outcomes. The final report and corrective action plan were provided to the DO at the end of July 2024. The DO scored 84.58% on the compliance review out of a total of 657 items. Of the total elements, 489 elements were met, 37 were partially met, 74 were not met, and the remaining 57 were scored as not applicable. DHHS did require the DO to complete a corrective action plan, or a CAP, that was reviewed by HSAG. The CAP remained open until the MCO achieved 100% compliance for all elements. Since this was the first year for the DO, it's not uncommon that there were several CAP items. The MCOs also had several CAP items on their first compliance reviews. For example, AmeriHealth had a similar score, which was 86.9% on their first compliance review during 2020. This slide provides the summary of the DO's scores for all the 16 standards. Because the DO scored between 80 and 89% overall, they received a confidence level of moderate. And I'll give you just a few minutes to review these scores, but we will go into them individually in the upcoming slides. So as previously mentioned, there are different numbers of elements or items within each standard. Items with a MET score indicate that the DO fully met the requirements. Items with a partially met score could be because there were multiple requirements within an element. For instance, if there were 4 requirements in the element and the DO met 3 of the 4 items, they would get a score of partially met. Not met items indicate that the DO did not provide evidence to demonstrate compliance with at least half of the components in a particular element. In the delegation and subcontracting standard, there were 47 items, which included a file review of delegation contracts. 22 items were met, 8 items were partially met. For example, some of the delegation files contained in the requirements contained all of the actual requirements, while other delegation files did not, such as information related to the appeal and grievances system. 17 items received a score of not met. For example, the DO documentation did not support that it evaluated the ability of the delegate to perform the activities that were delegated. In the care management standard, there were 10 items, which included a checklist. The DO scored 85%. 8 of the items were met. 1 item was partially met. Policies and procedures included the requirement that care managers remain conflict-free, but the DO did not provide evidence that the case managers adhered to the conflict-free requirement. And then 1 item was not met. The DO received a not met score for the required process to share the dental risk assessment screenings with the member's primary dental provider. DO scored 100% on the wellness prevention member education standard, which included 5 items. In the member enrollment and disenrollment standard, there were 17 items. The DO scored a total of 72.22%. 5 items were met. 3 items were partially met. For example, the DO's policy did not include that the DO could not request disenrollment because of the member's misuse of substances or any legal consequences resulting from substance misuse. 1 item was not met. The DO did not have a process for notifying DHHS when the DO identified information that may affect the member's eligibility. This standard also had 8 items that were not applicable. In the member services standard, there were 43 items, which included 6 checklists. The DO scored a total of 76.74%. 28 items were met. 10 items were partially met. For example, the DO's member ID card did not include all the required contents, such as a 24/7 toll-free member services hotline number. 5 items were not met. As an example, the DO's welcome letter did not inform the member of the right to a printed version of the provider directory or refer the member to the online provider directory. In the cultural and accessibility consideration standards, there were 10 items. The DO scored 80%. 7 items were met. 2 items were partially met. For example, the DO's policy did not include a reference to member accommodations for behavioral disabilities. 1 item was not met. The DO did not have a mechanism to track when members declined interpreter services. In the grievances and appeals standard, there were 166 items, which included 3 checklists, a review of 10 appeal files, and a review of 10 grievance files. The DO scored 84.25%. 122 items were met. 2 items were partially met. For example, the DO's provider manual did not include all requirements related to informing providers about the grievance and appeal system, such as the timeframes during which members could file appeals and grievances. 22 items were not met. For example, 7 of the 10 appeal files did not show that the DO did not provide a written acknowledgement of receipt of the appeal to the member. And then there were also 20 items that received a not applicable score. In the access standard, there were 28 items, which included 2 checklists. The DO scored 82.14%. 23 items were met. 0 items were partially met. 5 items were not met. For example, the DO's provider manual did not include the current timely access standards, and the DO did not have a mechanism in place to monitor provider compliance with the timely access standards. In the network management standard, there were 201 items, which included 2 checklists and a review of 30 credentialing files and 30 re-credentialing files. The DO scored 90.8%. 179 items were met. 7 items were partially met. For example, the DO did not demonstrate evidence of each provider's New Hampshire Medicaid ID, or that they verified each provider's New Hampshire Medicaid ID. 15 items were not met. For example, the DO's policies included the incorrect timeframe for completing credentialing and paying providers retroactively if the required credentialing timeframes were exceeded. The utilization management standard included 71 items, which also included a checklist and a review of 10 denial files. The DO scored a total of 94.26%. 56 items received a score of met. 3 items were partially met. For example, the DO did not have policies or procedures in place to notify participating providers and members at least 30 calendar days in advance of any change to the clinical review criteria. 2 items were not met. 2 of the 10 denial case files reviewed were resolved in 45 calendar days instead of the required 14 calendar days for standard requests. In the quality management standard, there were 11 items. The DO scored 42.86%. 3 items were met. 0 items were partially met. 4 items were not met. For example, the DO did not adopt clinical practice guidelines and disseminate them to providers and members. There are also 4 items that were scored not applicable to the DO. The DO scored 100% on the fraud, waste, and abuse standard, and that included 18 items. The DO scored 100% on the financial standard, which included 2 items. And they also scored 100% on the third-party liability standard, which included 8 items, and 2 of those were not applicable. In the health information system standard, there were 7 items. The DO scored 78.57%. 5 items were met. 1 item was partially met. The DO did not provide evidence that the health information system collects, analyzes, integrates, and reports confidential data. 1 item was not met. The DO did not have a patient access or provider directory application program interface, or API, in place. So this slide is a summary of everything we just discussed, and demonstrates the total number of elements, the number of not applicable elements, total of applicable elements, how many were met, partially met, and not met, and then the score for the DO. Okay, the second EQR activity we'll review is the Performance Improvement Project, also known as the PIP. DHHS and the DO collaborated on determining the topic for the PIP based on areas of lower performance. The PIP, the DO and DHHS decided upon was the dental risk assessment screening specific to social determinants of health. New Hampshire uses a rapid cycle PIP, which is 18 months in duration and includes 4 modules. In 2024, the DO focused on modules 1 through 3, which included submission of the initiation of the PIP, determining what their interventions would be, and then the intervention testing phases. The DO will submit module 4 for validation during 2025. HSAG validated modules 1 through 3 during 2024, and all 3 modules achieved all of the validation criteria. Next is the performance measure validation activity, or the PMV. For state fiscal year 2024, DHHS chose these 15 performance measures to be validated by HSAG. I'll give you a minute to review the measures. HSAG validated the performance measures based on several evaluation elements, which are listed here. The DO received an acceptable rating without any deficiencies for all evaluation elements and scored a high confidence level. Moving on to the Network Adequacy Validation, or NAV, HSAG conducted a geo-access analysis of the DO's provider network when compared to the members' residences. HSAG evaluated 5 provider categories for 3 regional areas. The DO met the time or distance requirements for all provider types in all regions except for dental, oral, and maxillofacial surgery in rural counties, which you'll see on the next slide. So these are the time and distance rates for the percent of members who had access within the applicable time and distance standards, separated by urban, middle, and rural counties. DHHS requires the DO to ensure 90% of members have access to the provider type within either the time or distance requirement. So dental, oral, and maxillofacial surgery is the provider type that did not meet the time or distance standards for rural counties. However, as you can see, while the distance metric was only 1.6%, the time metric was 83.9%. So the DO was close to meeting this requirement as well. Next is the Encounter Data Validation, or EDV activity. There were 2 tasks associated with the EDV activity: the Information Systems Review and the Annual Evaluation of Encounter Data Quality Reports. The Information Systems Review consisted of an assessment of the DO's information systems and processes related to maintenance and submission of encounter data. Findings showed that the DO did not perform any quality checks on dental claims other than the electronic data interchange compliance checks. Task 2 consisted of the annual evaluation of ongoing encounter data quality reports. The quality reports assess completeness, accuracy, and timeliness of the DO's encounter data files submitted to DHHS. The 5 standards are shown here. This slide shows the percent of dental and professional encounters that met the required standards. So based on those findings, the recommendations for the DO were to improve data accuracy for the member ID numbers for professional encounters and submit reconciliation files to DHHS and HSAG when submitting its dental and professional encounters. Next, we'll move on to the DMCM program evaluations. The first study is the Provider Satisfaction Survey. HSAG reviewed 6 areas of DO performance, including overall satisfaction, DO processes, access to DO staff and services, obtaining information, member information, and provider relations and covered services. There were 51 respondents for a response rate of 31.1%, and these are the scores for each domain. I'll go into the findings over the next slide, but I'll give you a minute to review the scores.
Ask a question.
Absolutely.
Sorry,
Please.
you know, because I am like a sponge, and so I'm trying to absorb all of it because I'm a dork, but I don't know what DMCM means.
I'm sorry, it is the Dental Medicaid Care Management Program.
Thank you.
Yeah, to layer on to having 100 acronyms in Medicaid, we also have different
Like
acronyms.
it, yeah.
we use.
In case you wanted
and
more.
DO is dental organization, just like MCO, but dental.
Thank
Yes,
you.
thank you.
No, thanks for asking, because we try to be mindful about acronyms in this meeting. We don't always hit the mark.
Sorry about that. So some of the notable findings are that more than half of the DO's providers did not accept new patients, while the overall satisfaction rate and satisfaction for several areas were at least 50%. Providers reported low levels of satisfaction with interpreter services. Additionally, providers indicated that the fee schedules were low, coverage was limited, and that the DO is disorganized, causing providers difficulty navigating the plan and submitting claims. Patients also reported concerns about procedure coverage. So HSAG offered several suggestions to the DO to improve satisfaction, including evaluating coverage to ensure it is comprehensive, improving access to interpreter services, and streamlining the claims submission and reimbursement processes. Next is the Secret Shopper Survey, which reviewed the dental locations and providers related to accuracy of contact information, acceptance of Medicaid members, acceptance of new patients, appointment availability for routine dental care, and provider information alignment with DO data. Findings included that all of the provider address information was correct and all locations offered the requested services. 89% of members confirmed acceptance of the DO and 81% accepted new patients. However, only 54% of the locations contacted were offered an appointment for the caller. And then of those, only 71% were within DHHS's required timeframes. Some suggestions HSAG offered were to consider conducting a review of offices' customer service processes to ensure staff are available during business hours, and to work with providers to ensure sufficient appointment availability for members. Lastly, we'll discuss the quality study, which was related to the, sorry, did someone have a question? No, okay. So the quality study was related to the effectiveness of the DO's education to members and providers regarding the extra cleaning benefit for pregnant members during their prenatal period. The study period was April 2023 through May 2024. There were an average of 430 pregnant members in a given month. However, only 17 members had at least one cleaning during the study time period. Only one member had a second cleaning, and no members took advantage of the additional cleaning benefit. Based on this information, DHHS developed a qualitative focus study to understand why members were not utilizing their benefits. The study was recently completed, and so the results will be shared as part of the 2025 EQR technical report. Some of HSAG's suggestions included focusing on improving the rate of members who receive their 2 regular cleanings during the year, to partner with MCOs to ensure pregnant members are aware of the added benefit of the dental service, and enhance current methods of notifying members about their benefits. And that is the end of the EQR presentation. Are there any questions?
So Sarah, before we get into questions, which I'm very looking forward to hearing from the group, I know we have Tracy and others from the dental organization joining us today. So I wanted to invite them to kind of offer some of their perspective and comment, in particular, context around the initial compliance review, the provider satisfaction survey results. I wanted to highlight too, I'm sure others noticed, the network adequacy standards are mostly met, but then there are concerns with finding timely appointments when asking provider offices directly. And then finally, just the pregnancy study. So, I'm sorry, I see Tom, you're with us as well. So I'll hand it over to Northeast Delta Dental to offer some commentary here.
Sure. Thanks, Olivia, and thanks all for permitting me to attend today. So I think that's a fair representation of where we are. I've always stated publicly, we've worked really hard, as Olivia knows. We meet regularly with the state. We meet regularly with our all of our partners, the mobile dental clinic, which has been running almost every weekend since inception, addressing, the access issue that was alluded to in the report. So our effort, I would give our effort an A+. I would give the results, the 84.5% is fair. We know we have more work to do. It's certainly not lack of effort. I think this report will be really helpful as we continue to manage our sub vendors, and I'm personally committed to addressing these. And later today, as a matter of fact, we'll be having a meeting with DentaQuest, one of our major partners, to address it. So it's been a challenge, but I also think everybody needs to know that based on people that I've met at the mobile dental clinics and the fact that we've seen over 20,000 Medicaid members, that this was probably one of the best professional moments in my life. Even though I'm generally been an A student, I think the 84.5% is accurate in terms of the result, and we know we have more to do, and we're committed to continuous improvement. That's what we're known for with Baldrige quality, et cetera. So I won't comment on anything specifically. I think it was a fair representation, and it really gives us a nice blueprint to continuously improve. And Tracy, who works with me on the day-to-day, I don't know if you have any specific comments you want to add, but we are committed to using this report to continuously improve. So thanks, Olivia.
Tracy, I can see that you're speaking, but I don't think your audio is connecting. I think you're probably good. Yeah, there you are.
All right, perfect. I had to switch my microphone. My apologies. So I want to start off by thanking the HSAG team for, walking us through this first year. We had to implement very quickly in a 3-month period, and some of those implementation activities extended into the first year. It was a real learning experience to implement a program so quickly. But the support from the state, Olivia and Dr. Finney, really helped a great deal. And then this particular audit and the way that HSAG managed it and helped us through this first year and understanding the process itself and the requirements also helped us learn and understand where we still had gaps that needed to be addressed. And I want to tell you that throughout the process itself, we began addressing these gaps. We didn't wait until the report was released because we did understand the importance of making sure that we were doing everything we should be to administer the program correctly. I do want to mention that we are meeting the standards for oral surgeons. We began meeting those in July of 2024, so it was after the measurement standard in this audit. So I want folks to feel a sense of relief around that. We are working hard. We do not have enough oral surgeons. There aren't enough oral surgeons even in New Hampshire to do the work that we want, but we work extremely hard partnering with these offices to ensure that members can get appointments through our case management team. We have advocates that work on behalf of members to make sure that where there's urgent situations, they get appointments. Also through our teledentistry partner, we make urgent referrals where needed to make sure that they're seen as quickly as possible. I also wanted to mention that with, the provider satisfaction survey, Sarah noted, so where folks were satisfied, but there was a certain percentage of neutral responses that were fairly high in many of these categories. And after many years of looking at provider satisfaction surveys, we also know that when providers don't say anything, they're often generally satisfied with the program. So we're not taking that as they're definitely satisfied and we shouldn't work on these items, but we do want to make sure that we mention that. In terms of claims and auths and the lower satisfaction in that area, we've kind of narrowed down the challenges around where they're seeing some issues, and most of those have to do with periodontal services and not understanding how to bill for those services properly, how to use the right codes. So we're implementing education programs. We're making sure they have access to the tools that they need. We're also working to understand how we can streamline the process for them. And one area is making sure, for instance, when they submit a prior authorization within the time frame for dentures, after a member has already received a denture and they feel like it's medically necessary, giving them the opportunity to do that and having that reviewed versus having to submit an appeal. So we recently made that change. Also reimbursing providers for the additional time they're spending with special needs members. We just implemented a code that allows for that additional time and those additional resources to be covered. And so those are just a couple of the things that I wanted to address. Dr. J and Pat Whalen are here from DentaQuest. Did you have any notes that you wanted to make?
Thanks, Tracy. This is Dr. Jay Millett. I am the dental director for the Northeast at DentaQuest and a New Hampshire provider. Previously, I worked at Harbor Care, federally qualified health center in Nashua, and also at Concord Hospital before joining DentaQuest. And Tracy really gave a great overview. I think one thing that's been really helpful when we are talking about provider satisfaction, where providers think they need more education and where they could get more guidance. I always make myself available to my colleagues in New Hampshire and able to explain what typical Medicaid criteria is. I make myself available to meet in person and then also on the phone with them to make sure that they have everything they need. They know they can reach out to me anytime, as well as a provider engagement rep who is a dental hygienist in the Claremont area. But in addition to that, myself and my counterpart at Northeast Delta Dental, Dr. Joe Arante, run a quarterly dental advisory committee with some dental providers who have joined the Medicaid program early on. And we always receive great feedback from them to understand what the pain points are, what's going well. So we really have a very strong boots on the ground approach. We're making sure that providers know that they have their resources, that they're local people who speak the same clinical language as them. So we always make ourselves available to help make improvements based on what kind of feedback we're receiving from them.
So I would just augment that. It's been really helpful having a true New Hampshire dentist like Dr. Mallet involved, because when dentists contact me, they always give me great feedback that they have access to Jay and the fact that he knows the New Hampshire environment, if you will. And we have, early on in the program, we did make obviously some fee adjustments and the other tweaks, that Tracy mentioned, and that's based on this open relationship and positive relationship that in general Delta Dental has with all of our commercial network, and the subset of that, of course, are the ones that are taking Medicaid. So this is having Jay has been a real positive in the program.
Hello, everybody. I'm Pat Whalen. I'm the client partner here at DentaQuest, who works with Northeast Delta Dental and the state, and of course HSAG. And just really want to echo Tracy's sentiment overall that HSAG and DHHS have been wonderful partners through all of this and really helping us guide towards making sure we're administering the program in the way that they intended and the way that it's laid out. I don't have anything particularly salient to add beyond that my colleagues haven't already gone over in detail. So I won't belabor the point, but really just thank you all for the inclusion in the process here and really getting to see how it all turned out for y'all.
I think that was everyone. Thank you for joining and bringing that breadth of feedback to the presentation. Are there any questions from attendees today? Anything in the chat, Kristen, that we can't see?
Just Madeline Ork said thank you for the excellent presentation and services of the HSAG, but no question.
Well, I'll just echo again, I really appreciate the engagement on the presentation. I think in the beginning of the program, we were so focused on getting contracts signed, providers signed up, and easing the administrative process as much as possible for them to participate in the program. And now we're, it's great that we've seen over 20,000 people served from this program, and really turning our attention now to refining it and making sure that everything's operating at, as Tom said, a student level, but also increasing access to services with the network that we do have. So it's just so important, we have such a wide array of people joining the MAC, that if you are hearing things or getting feedback on the dental program, that you're bringing it forward, because that's what helps us respond quickly, with Ned and DentaQuest.
I would just add, I ran into Dr. Finney in the airport in Las Vegas.
I heard that. That is such a funny coincidence. Right.
I think retirement is treating her well.
Right. No, it's a good place to find her.
All right. Shall we move on?
I think so. Yeah.
All right. Thank you, everybody. Great work.
Thank you.
All right. So Dave, let's talk about enrollment and eligibility.
Green here. So this is the report for April, or the month ending April. Not too much change in the overall enrollment characteristics of the Medicaid program. Similar numbers for standard and granted advantage with enrollment, just above 184,000. And this was taken at the first of the month. It's a point in time snapshot. This is a similar slide to what we've shown in the past. So our low point in enrollment after the unwind was in November of 2023, and this just looks at how each of the categories have changed since then. So we've seen some expansion of the adult group under Grant Advantage, and then the two children's groups, low-income children. And I think a lot of that is based on the continuous coverage requirements, the 12 months continuous coverage requirements for children, which went into effect January 1, 2024. And this is the same look, but a more detailed breakdown with the actual enrollment totals on a monthly basis. This is our ex parte rate slide. So for June, it was 76%. I think just a reminder for everyone on the MAC, the E14 authorities that we currently rely on expire effective at the end of the month of June. So for July, I would expect this E14, this ex parte rate to decrease. And what the E14s allow the department to do is rely more so on older external income data. And if certain characteristics are met, assume that there has been no change in the person's income, and then passively renew them. And for some individuals, where that income data that's being used is from when they first applied during the pandemic, so 2020, 2021. And so the federal government for all states wants more recent income data to be feeding into eligibility determination.
What do you expect this number to change to?
When we've done some analysis, I think it looks like there's about 2,500 to 3,000 cases per month that will not go passive. And currently we're seeing about 50% of cases that don't go passive close. And so I think the ex parte rate will decrease by about 20 to 25%. And we could have more closures if individuals not submit their redetermination applications. But we're working on a communication campaign. Vern's got one going now, and we're making it stronger and better in the future to target individuals that don't go passive before they close, to help them to just get the word out. And then I think the other big piece of this is currently for waiver participants in long-term care, they get extra time if they haven't completed their redetermination, and that also goes away at the end of June.
Say that again?
So currently, if you're in a waiver and you don't complete your redetermination, you get an extra 60 days. That expires along with E14s at the end of June. So people will need to complete their redeterminations by their redetermination month.
You know how people can follow up if they fail to provide a document?
Yep.
Is it for 90 days?
It's, yep. And
Will that go?
Nope, that's staying in place. The reconsideration period is 90 days. The change will be that individuals that currently get those extra 60 days, they'll close. And if they submit the missing information during the reconsideration period, they'll reopen and it'll retro back, but there will be.
But they don't need an 800A when they do that, right? Like they don't need a quick app when they.
No,
They
they
just
say
need to
they're
submit
missing
their
an income.
document.
Yep,
Yep,
they could just
okay.
submit the income. Yep.
Can I just say, I want to make sure everybody hears, because your paper campaign's going great.
Oh, great.
They're all over the place. So you're getting pink notices, or your members are getting pink notices that are saying, hey, this ex parte stuff is going on, there's a change coming, be aware, and if it affects you, you're gonna get a yellow piece of paper.
Yeah.
So just be aware of that, right? Pink paper says, warning Will Robinson, look for a yellow piece of paper.
Yeah. Yep, and so every person that's up for a redetermination, that pink piece of notice is gonna go out on a monthly basis about, I think, essentially 2 months before their redetermination date. So the people that are redetermining in July just got their pink notice. And then the renewal application is on a yellow notice of that pink notice says, keep your eyes out for mail from the department. And it'll be on yellow paper. And if someone is just, if they're go green, and so they only get electronic notifications, we're sending out the same links, yellow and highlighted in yellow, so it's in their NHEZ account. There are text messages that go out as well as reminders and emails.
Thank you.
This is another metric we're tracking around voluntary reported closures. So if someone reports that they've moved out of state, or they're now over income or something. So in 2024, we had just over 10,000 individuals that reported voluntary closures, and currently we're at 4,100 through April. These are the looks on the dashboard. They look very similar to the prior months. This first one is just for the adult population. So there were just over 6,900 adults, Medicaid adults, up for redetermination, 11.5% closed, 84% completed the redetermination, and 78% of them were passive. The largest closure reason was for failed to read at 58%, followed by income at 15%. Next dashboard is for children for the month of April. So there are just over 4,400 children up for redetermination, 13.5% closed, 80% completed the redetermination, 67.6% were passively renewed. But there's quite a, when you look at adults versus children, 77% of the children failed to read that closed, compared to the adults, which was 58%. This is the waiver population, and I did this one in counts rather than percentages. So there were 993 individuals up for redetermination that were in a waiver eligibility. And for the financial determination, there were 8 closures and 819 completed the redetermination. And this is a drill down into that population, just looking at the CFI population. So there were 260 individuals up for redetermination, 1 closure, 226 completed the redetermination. The large majority of those were passive, 220 passive renewals. And it's the same look for nursing facility. So there are 295 individuals up for a financial redetermination for April, 3 closures, 199 completed the redetermination, and 182 of those completed redeterminations were passive. And this, sorry, I'll fix this when we send it out, but this should say April. And this is the CMS reporting that we made for the month of April. And so you can see 87.1% retained their Medicaid coverage. This is in line with other months. It seems to fluctuate from 85% to low 90s. And then we have the total closures by reason down here with 66.5% of the April closures were failed to read, almost 14% were due to income. And Vern, I think I'll kick it over to you for the communication campaign updates.
Thanks. So again, with the communication campaign, we have the MCOs making phone calls the month after individuals close. So what we're looking at is March closures. We call in the month of April. Numbers stayed pretty close. We were looking at 820 individuals the previous month. In April, we had 806 individuals to call. We were able to reach 296, or the MCOs reached 296, which is 38%. That was up 4% from the month previous to that, which was up 4% from the month previous to that. So it's good that we are seeing an increase in the individuals we're able to reach. So engaged about 26% of the total number, or 26% had already done their redeterminations. And it's interesting, this month, we saw a decrease in those who had completed their redeterminations already, but an increase in those that were aware that they needed to do their redeterminations. So I don't know, the weather shouldn't have been a factor because it wasn't that great, but it was interesting that we saw that. We also, you'll see in the next slide, saw the same thing for individuals that the Medicaid team was calling out for, which would be the previous month, following up on messages that had been left by the MCOs.
Can I repeat what you said?
Sure.
A decrease in those who completed it, but an increase in those who knew they should have.
Correct.
Okay.
So more people said, yes, we know we need to do it. Fewer people had actually done it.
I get it. They say a little bit more than that to us, and it's sometimes flavorful, or colorful, I should say, so
Well,
I get it.
we can only be so called.
Yes.
New insurance, for those that we reached, we saw that number stay pretty consistent. It had been 16% the previous month, 17% last month. Unaware with the address correct, again, consistent to unaware, address incorrect, the same. Moved out of state, we're still running about 4% of those that we reached. We did see a jump, and that went from 4% to 9%. And so that other would include anybody who had indicated that they no longer needed it, but didn't tell us why. It could also be anybody who's passed along. Those will fall into that. But this is where we also see some of those individuals who had that extended period of 60 extra days, because they will fall into this group. Now, they don't get a phone call.
Yeah.
And so they'll fall into this group of other showing up in those individuals who haven't done their redetermination. The READY complete, but they were found to be ineligible, stayed again pretty consistent, 3%. Previous month was 2%, month before that was 3%. It stays right around that, about 3% of the individuals. Let's see, I think we'll go ahead and move to the next slide. So the Medicaid unit, they completed 120 individuals calls. 51 were able to be reached, so they averaged about 45, almost 46% of the calls that they made. It resulted in a contact with an individual. And this is where we saw some of the change here as well. So 10 had completed their redetermination. So these would have been individuals that received their message from the previous month from the MCOs. That was a change. So we had seen the completed ones. So 10 did it. That was a decrease from the previous month. But 24 were aware that they needed to do it. So again, we saw individuals who were aware that they needed to do it but had not completed it yet. No one, it was interesting, no one of the ones that we reached this month indicated that they were not aware that they needed to do their redetermination. So that's good. At least they knew that everybody knew they were supposed to do it. We did find in that following up 9 individuals who had new insurance, 4 adults, 5 children. So one thing that I did want to point out actually on the previous slide, but I'll just mention it here, is 49 individuals were found to have new insurance of those that we had reached, and 36 of those were children. So that was a nice increase in children who were being covered by insurance other than Medicaid. Anybody? Oh, and as David said, we are looking to update the campaign. We know that we're going to lose the E14s, which is going to have a little bit of an impact on individuals who would just normally fall into that, being able to redetermine without doing any of the paperwork. And so we are going to start looking at have the MCOs call the individuals the month that they're closing to try to reach them before they actually close, to get them, if nothing else, started through the process. And then the Medicaid team would follow up the month after people have closed instead of 2 months after. So we'll just move everything up a month. And we're just putting the finishing touches on what that's going to look like.
Do you know if you're mostly calling cell phone numbers or home phone numbers?
We're calling whichever number is listed, yeah.
I was just wondering how it would appear on your phone. Spam likely, or their insurance company that.
Well, from the MCOs, it should show that it's the MCO that's calling. And from the state, it shows up as the state's calling.
That should be helpful. There's so many scam calls that are like, you're using your social security benefits. And so it sounds like the text might actually be kind of similar. And that's why I was asking what kind of like legitimacy you can give in terms of the setup of the call.
You know, also, I'll just say, put out there, and it doesn't warrant any change in action, because I certainly, even though I'm here for CBHA, I'm not speaking for 10 centers, but it's a lot to get a lot of calls. And we're doing the same thing that you're doing. Maybe a little bit more aggressively and knocking on doors. You know, doing everything we can to make sure that people don't fall through the cracks. And so just, I guess, an awareness, so that if the downstream feedback becomes colorful, it's a lot for people. It would be a lot for me. He kept calling me. But we're doing everything we can to keep them from falling through the cracks.
Right.
So we're partnering with you as it happens, and just a general awareness about that.
Oh, sure. It is interesting. We have had, the 1 and 2 offs where they actually appreciate the fact that they've received so many calls, because at least they know people care.
Yeah.
But there's going to be the other individuals at the other end of that spectrum where it's just like,
yeah, enough already.
Don't make me have to change my number.
Yeah. Thank you.
Thanks.
Moving right along, the usual and customary updates.
Our department updates list, which grows a little bit every few meetings, but we spoke a bit about dental already earlier, so I won't go too much in depth, but we have 190 contracted providers at 134 locations. We're up to 173 mobile events with over 1,800 members served at the mobile sites. And this Thursday, the mobile van will be in Manchester, followed by Nashville, Concord, Laconia, all in one weekend. So I'm working on a map animation so that we can watch the van travel around in future updates. On the DDU update, I'm going to pass it to Scott, who I saw just came on camera.
Yes, good morning. So Kristen, I don't know if you want to pull up the sheet. So as you'll see for the children, we currently had, as the end of April, we had 57 children pending, with 3 of them over 90 days. We had 200, which is down slightly from the month before. And then we had 234 adults pending, with 13 of them over 90 days, which is down from March as well. Some kind of important information. So out of those 234 adults pending, 68% of them have Medicaid through another avenue, so Granted Advantage or TANF or another avenue, and 26 of the children have Medicaid through another avenue. I wanted to point out a couple of things. So for the month of April, we received a total of 204 new applications came in, so slightly up from March, only by about 50 or so applications, so nothing huge. I was able to run some reporting for the first quarter, so January through March, and our average data process for the first quarter was 64 days, so well within the 90-day time frame, with a few days to spare. For the first quarter, we're running at 90% timeliness, and then that's total cases, including the cases that we have to send multiple requests out, or we receive the application late, or need to get additional releases and such. And then if you take those cases out, we're at a 99% timeliness. So, I mean, it's really good. Our team is really pulled through. We're working well with the contractors and just continuing to improve. So no worries on this end. Does anybody have any questions?
That's great, Scott. Thank you. I
Yes.
look forward to seeing it every time because it's really trending in such a good direction, and it just continues to do that.
Thank you.
So we're excited to present on today's agenda as well, the DHHS roadmap. I'm going to ask Jordan to share some slides we have on that. Thanks, Jordan. So MAC may recall around this time last year, we presented on the inaugural DHHS roadmap, which is part of a new strategy from the department to give more transparency on our commitments and priority work across the many divisions under DHHS. We had a great conversation last year just about different topics and priorities coming from members as we planned ahead to the first roadmap. Jordan, can you go to the next slide? On the left-hand side, just a refresher, that was our original roadmap document that we shared. And then in March, we released the mid-year report, very long, informative document. And I linked to it here. It's also linked in our agenda, just covering on the progress made so far for the 2024-2025 roadmap. Next slide. Sorry that this is very small. I didn't do a good job of making it very readable, but just to recap, there are many, many, many milestones and initiatives within the roadmap that kind of bundle into three commitment areas. Those are invest in people and culture, promote thriving communities, and improve customer service. Most of the areas that Medicaid is either leading on or playing a leading role in are under the promote thriving communities commitment to. Next slide. So we're still working to finalize the roadmap initiatives that will be in the next roadmaps. So some of these are a little bit subject to retitling or rescoping, but we wanted to give you all some insight into where Medicaid's focus areas will be in the future roadmap commitments. I'll hand it to Jordan to speak to the first two.
Thanks, Olivia. So I know we've pretty routinely updated MCAC on these two initiatives, so I'll just kind of quickly touch on, where we stand in terms of the roadmap. So this first one supports successful transitions into the community for individuals after incarceration. That is obviously referring to our community reentry program. So sort of what we've accomplished so far in terms of the roadmap, we have all of the federal authority that we need for the adult program through our 1115 waiver. We launched in the state prisons, across the state prisons in January. And so we've been tracking participation and performance of the MCOs and, working with those incarcerated individuals since about mid-February, since we had like sort of a slow rollout. What we're kind of pivoting towards now is sort of just looking through our process. Obviously, community reentry involves a ton of partners, both within DHHS and of course COC. And so there are a lot of little pieces of this process managed by a lot of different people. So we're just sort of now trying to, do some quality improvement of both the process and make sure that we're getting exactly the outcomes that we're looking for. So we're pretty engaged in that process now and doing some auditing of our original, first cohort of individuals. For youth reentry, similarly, we launched in January. It was a slow rollout. So we've had youth in the program since about March. There are many fewer youth, thankfully, coming through the system. So we have a much smaller kind of first cohort, but we're doing sort of the same process improvement initiative there. And, we're really finding, I will say overall, I think our big takeaway is while the process is very complicated, it involves a lot of different pieces, the MCOs are working very, very well with our carceral facilities and are really excited about the work. And so we're very pleased with what they're accomplishing so far. On the Medicaid to schools, so continue federal funding to local education agencies is referring to our Medicaid to schools initiative. Again, I've updated this group a number of times, but really where we're at is we spent about the last year developing an RFP that I believe was shared to this group. And that RFP is for a vendor to support the state's transition to a cost-based reimbursement model called a certified public expenditure. At this point, we are kind of in the final stages of, we closed out the RFP, we scored, we selected a vendor, and we're in the final stages of sort of confirming a contract with that vendor. So we expect to get that to GNC in June and hopefully have a July 1 contract start date. And then of course from there, the vendor will work with us to start training schools, developing resources, and rollout of that new model will be for the 26-27 school year.
Thanks, Jordan. We're also partnering with our public health division on a few initiatives as well. One is, continuing from the prior roadmap around maternal and child health. So some of the initiatives we were focusing on in the prior cycle were around, the addition of doula and lactation services to the Medicaid state plan, which is underway now. And so looking forward, it'll be about bolstering and supporting those services, ensuring that our priority quality measures in this area are doing well in the MCO program, and then also the sustaining of our Medicaid opioid misuse model that we manage currently in partnership with Elliott. There's likely going to be an initiative around lead, which I know has been a big focus area for our MCO contract, currently in place that started in September, as well as primary care services and access. So this will be building on our 3.0 objectives around increased relationships between Medicaid enrollees and their primary care providers, and leveraging health risk assessments and comprehensive medication reviews and other services that we've either added to the program or enhanced with funding or otherwise. Next slide. This is just recapping. So, our hope today is to collect any feedback, which is, always, oh, sorry, Anne, go ahead.
Sorry, can I, just to jump back to those initiatives are where Medicaid might be most engaged in the division of Medicaid services, but part of the roadmap really is the integrated approach across all of our initiatives. And we also have continued initiatives on the system of care for healthy aging, which I'm sure this group is really interested in, as well as in continuing to work on strengthening access to services for individuals and access and services, for individuals and families. We're really looking at our customer service around eligibility, issues and making that more easy and accessible. And then also initiatives around children's behavioral health too. So I know we have individuals on the phone if anyone wants to speak to that, but Medicaid, the Division of Medicaid is really inserted into a lot of these initiatives. But this group is probably interested in all of
That's a
those.
great point.
So, just somewhat.
I am particularly interested, not exactly in this moment, but to hear more about the children's behavioral, but the customer service initiative and where that's going.
Same. That's it. I think of customer very broadly, so it would be really nice to understand sort of who you consider a customer.
Sure.
And what initiatives are behind sort of improving that experience.
And that's so in our commitments we have people and culture, thriving communities, and customer service. So customer really is, it's broad. It's really all of our stakeholders, whether that's a provider or
Vendor.
a client or family.
Vendor.
Well, and I say provider, but yeah, anyone we contract with. So we're looking, continuing to improve our contract management, our payment methodology. So that's also under customer service, which would impact this group too. Less programmatic, more on the administrative business side of doing business with the state. So continuing to do that. And so it's anyone who would be our stakeholder.
Thank you. And so yeah, great questions already. And then any other further questions or feedback folks want to share today, we're all ears. From here, we'll be finalizing some of these roadmap initiatives, and when the actual roadmap deliverable is ready for public release, we'll be sharing it and probably representing a bit, with the MEC as well. And then just like we did last year, we'll continue to update this group as well as the BAC on milestones and updates across the initiatives that Medicaid has a role in, or is just a party to.
Thank you.
Any other questions, comments in the chat? Okay, cool. Great. So I'll pass it back to Jordan and Carolyn for adult reentry. I mean, I guess we kind of covered it already, Jordan. What do you think?
Yeah, unless anybody has specific questions, I mean, that's sort of the high level update I would give anyway. But if there are any other specific questions, I'm happy to answer.
Going once, going twice on reentry.
Can give you a few enrollment numbers, just current that we
Oh, great.
received
Thank you, Caroline.
this morning. Just they're very high level. So for adult reentry, we have 37 participants to date, and 15 of those participants have been released. Youth, as far as youth, excuse me, we have 7 participants to date, and 2 of those youth have been released. And as we've said in past meetings, each MCO is represented. Not necessarily equally, but they are all represented. So they've each had representation. And as Jordan said, they're doing a great job and really engaging pre and post release. So it's been going really well so far.
Ollie?
I just had a quick question about the reentry program is related to the budget with the cuts to DOC. Does the department expect that there will be any impacts to the program with the cuts if they're not, if they don't do something in the Senate to put some of those positions back into the budget?
I can take that. I mean, obviously we can't anticipate exactly what's going to happen in the final budget phase. I think that if the cuts proposed by the House were to stay true, we'd have to look at what our timeline might be for continuing implementation of community reentry, whether, looking at the capacity at DOC. But at this point, we have the same information that you do, so there's no guarantee that those cuts will sustain through the Senate phase and through the final budget. So at this point, we're marching forward and continuing to partner with DOC, and we'll have to look at modifying our timeline and what we can accomplish if DOC doesn't have the same thing. But it's a great question, and it is on our top of our minds. But we're just continuing forward. So we'll circle back with more information if those cuts are to remain.
Thank you.
I mean, with so much of the budget, right, and that impacts our roadmap as well. I mean, what's going on in the federal government, what's going on locally. We won't know until all those final decisions are made.
Any other questions? On MCO 3.0, we're working towards our amendment number 3, which we anticipate to bring to GNC in July. Is there anything you want to add, Dave? Okay.
Yeah.
And similarly on the HCBS spending plan, I don't think we have any updates for MAC, and this will probably, I'm anticipating, come off the agenda in the next few meetings as we kind of phase out of the effective dates of some of those areas. For waivers on the 1915J, we're continuing to work on the addition of other providers to this service. So we'll include any updated documents or guidance materials when we have those ready to share here. I don't have any updates from our last meeting on supportive housing. And then the 1915B waiver renewal for dental is still under review with CMS. Under the 1115, Carolyn, is there anything you want to share today?
And no other updates, just the reentry is going strong. So that's my main focus right now.
And then we continue to have the CMS informational link around our Medicaid to Schools grant. Jordan gave us a lot of updates already. Anything else you want to add, Jordan, on Medicaid to Schools?
I guess since you mentioned the grant, I mean, really all of the work besides, maintenance of the current program under the current model has been with the RFP, but we did apply again we had to submit a continuing application for year 2 for the MTS grant. So just so everyone's aware of that, my understanding is it's not our grant is not at risk. It's just sort of a maintenance process to let CMS know what our plans are specifically for year 2 and how things have shifted a little bit. So we did submit that last month, and we got some initial feedback from CMS. So I think we're in a good place there. Hopefully we will be able to get approval through a waiver with our internal waiver to hire for the grant project manager position that we're looking to hire. That's 100% federally funded.
Thanks, Jordan. Kara, I saw that you maybe come on camera. Are you hoping to ask
My
a
camera's
question?
not working. I'm trying, but
Joe 8005.
Oh, I'm sorry. Okay, got it.
She's just trying to do it.
No problem.
yeah, I
just wanted to make
was
sure we
trying
weren't-
to be polite and come on camera, but that's just not happening today. So
Okay.
I can give a quick update. The committee met last week. I have all of the notes and comments that members have submitted from the past week, and I'm going to send those over, Kristen, this afternoon. I don't anticipate a whole lot more back and forth. I think there are still a couple of areas that we've asked Brian for some clarification and that we don't necessarily have an agreement with right now, but we can certainly see what comes back from the department for comments, and then we can update MAC from there. Do any of the members have anything else to add that I'm forgetting?
Yeah, I'm just gonna reinforce or sort of underscore that there are a couple of pieces of the language that we would not agree with.
Yeah.
And we think that we can come to agreement, but heads up. Yeah.
Thank you.
Yeah. That's it. Thank you.
Thanks, Kara. Circling back to electronic visit verification, we did see a significant increase in visits in April as compared to March, by almost 10,000 visits. The consumers, work, and providers using the platform has remained relatively steady over month, and seeing a small increase in workers. I'm happy to continue providing utilization numbers like these in future meetings, but I just want to check in too if this is something MAC wants to keep on the agenda as a standing item or not. yet, so maybe we'll talk about it in the next meeting. Just wanted to float, what we wanted to keep on versus this came up from a specific request a couple meetings ago. And then for our last update today, I'm gonna actually ask Kristen to stop the meeting recording. We wanted to screen share material that we have through NAM. Oh, sorry. I think I see a question in the chat about community health workers.
And it's from Christine Starter. I am sorry if I missed this, but is there an update on the community health worker spa?
I think unless you have one, Jordan, we'll have to take that back.
Yeah, I guess the update is just it's on our like near term submission radar, but it's not fully drafted yet or ready to be submitted.
Does that answer your question, Christine?
Yep, thanks.
Thank
Can
you.
we add that for our future agenda so that we don't lose track of it? Because obviously Christine's interested in it.
Sure. Yeah, we'll add that to our department updates.
Thank you.
Sorry. I am
Go ahead.
interested because the public health funding that was funding community health workers got pulled by the feds. And so there's no funding left for those CHWs. And so the quicker we can, I know you're all very busy, but the quicker we can get that through, the better for the organizations that have CHWs.
Yeah, we might want to connect separately, Christine, just to maybe discuss further where it may or may not overlap between the Medicaid services and the federal funding you're referencing. So we'll reach out. Yeah, thank you for raising.
I'll stop the recording.
Yeah, that'd be great, Christine.
Yeah, I added.
You want to explain why we're stopping?
Yes, I will explain it. So we know that there's been a lot of questions around federal